All right. Hello, and thanks for listening to another edition of The Veritas Road. I'm Carson, back here with Murph, and today we have a fresh new face
You're not
joining
going to
us.
ask me how I'm doing?
How you doing, Murph?
I'm doing great. Now continue.
Good, buddy.
Fresh new face.
We got a fresh new face, either a large man or a small bear, depending on which side of the evolutionary discussion you sit on. Robert Thomas. Robert, what's going on, sir?
Not much, man. I've usually not referred to as a bear. I've got another buddy in Tulsa who's referred to as the bear.
Ah, well, I mean, you've grown a beard, and you look kind of bear-like right now.
I appreciate that. I mean,
That's a compliment.
It's a mild compliment.
Yeah.
But I also think it's saying I need to get back on the diet.
You look good, man.
Thank you.
You look good.
Just good diet of LaCroix.
Yes.
Sugar water.
All right, so Robert, tell us a little bit about your qualifications. I know you've been doing a little bit of work in the accounting sector, right, for a little bit?
Yeah.
So I know that was a really terrible introduction I gave you. So
Go
tell us a
straight
little
to
bit.
business. Ask him a funny question and then get to business.
Okay. What's a funny question?
What's your favorite color?
My favorite color? Typically, my favorite color is red, but orange is a good color.
Does that
Black
mean
is a
you're
good
attracted to
Do you sleep in your underwear or not?
color. I'm going to plead the fifth.
Okay. See, no, that's a good introduction.
See, I
Yeah,
sleep
there you
nude.
I mean, some people sleep in
Just for the
pajama
record.
pants, which I would burn up,
Man.
It's way better for you to sleep naked, just so everybody knows.
All right.
So Robert, yeah, tell us a little bit about you and what you're qualified for.
Sure. You guys know this, but for your listeners, in 2016, I graduated from Freed-Hardeman University. I have a BBA in accounting and an MBA in accounting.
Whatever that means.
Yeah, whatever. Those degrees. Bachelor's of Business Administration and Master's of Business Administration?
Yeah.
I have the same thing for those
Okay.
two there.
Yeah. So, yeah, Murph and I literally took the exact same classes. So I graduated in 2016. I went and worked for a company down in Texas that operates nursing homes, long-term care and skilled nursing homes in Texas, Oklahoma, and Colorado.
Dang.
Yeah, pretty good size little regional healthcare setup. And so I went down there, worked with them for about 2 or 3 years. Got all the healthcare stuff together. Worked in the business offices. After that, I left and went to a large international accounting firm. I've been working for them for the last 2 years, and yeah, I did. I packed up my stuff and went east. It was pretty great.
Gotta love ambient people interrupting our
So yeah,
podcast.
We love it.
So yeah, that's what I've been doing, and so I've been a public accountant. I've worked on state and local taxes. It's pretty good.
So I have no idea what most of that
Yeah,
means.
that was a lot of information you
To be
just
honest
left
with
out
you.
there. To sum it up, you started out in a nursing home company after the Freed.
Yeah.
And for reasons you may or may not heard about later, you left.
Yeah.
Now you're in the public tax world dealing with state tax law,
Yep.
right?
Yep.
Interstate tax law.
State
Basically?
specific, but yeah, typically as it relates to interstate commerce.
Is that
so
as boring
Is
as
that
it
directly
sounds?
affected by the 10th Amendment? And is that as boring as it sounds?
Remind me which one the 10th Amendment is. I just know the Commerce Clause is a big deal in whatever I deal with.
Carson, pull up the 10th Amendment. Quick.
Yeah,
quick,
I can't.
Quick.
I don't have internet right now, guys.
You don't have Wi-Fi?
So anyway, is that job as boring as it sounds?
I don't think so. I love it, but I could see how somebody who doesn't know what it is would find it very boring. So,
Okay, so I obviously am finishing up a degree, as anybody who's hopefully listening knows at this point.
I'm very excited for you.
Health sciences, and what I'm interested in is your work in the healthcare field.
Okay.
And specifically, what it was like. It was an assisted living type of home you're working in, right?
So the home that I worked in specifically was actually kind of a dual threat. So they had an assisted living facility attached to it as one little separate part, and there's like double doors that divided it. And then there was another piece that it had a couple of long-term care beds. So when you think nursing home, grandma goes there until she passes on.
Right.
Like had like 20 of those beds.
Okay.
And then the other 80 beds in that home were skilled nursing, which is basically people who grandma goes and gets a knee replacement surgery. She's not like down and out. She's not going to die.
Right.
She's getting some work done. She's been in the hospital. They're going to rehab her, get her up to speed, and then they're going to send her home.
Okay. So what?
So that was truthfully, that was the bulk of our business.
Right.
Was doing that skilled nursing type service.
So not like palliative, like we're here to make you feel better until you pass on type care, but
no.
mostly
Rehab.
Mostly rehab. That was what my home specialized in. And like I said, there was a very small population of long-term care people. And truthfully, the reason that we had that population was because they were mostly Medicaid beds, and they would keep those people in those Medicaid beds so that they could have a contract with the state of Oklahoma to get Medicaid funding, and then they would, whenever somebody else who was Medicaid came in through the skilled nursing piece, they could bill the skilled nursing co-insurance from the state of Oklahoma. That's a very technical term. So, but basically, when Medicare pays for a stay in a skilled nursing facility, there's usually a co-insurance amount.
Okay.
And so
What is co-insurance?
So co-insurance is what the people pay, right?
yes, that is the
copay.
So it's a portion that is not covered by Medicare. Now, people can opt to buy co-insurance that will cover that copay, and then they just pay a premium to have that insurance. Or they have nothing and they have to pay that co-insurance out of their own pocket.
Okay.
Or they qualify for Medicaid, and the state will pay that co-insurance for them.
So let me get this straight.
Yes,
Okay.
I know. I know it's very technical, but
You pay a Medicare tax for your entire, let's say you're working 50 years.
Yeah.
And then they don't pay for everything.
No, they don't. They do not. No.
So what's the point?
And here's the spiel I would give an old person. Okay.
Uh-huh.
So old people kind of have an option. They're entitled to Medicare, and so they will receive a Medicare card if they work the requisite number of quarters. You have to work 40 quarters over the course of your career. So basically, you have to work 10 years in the workforce, and they'll guarantee you Medicare. And so once you've done that, you are entitled to Medicare, and you become eligible at 65, and then it will last until you die.
So if you live to be 200.
Yes, you would still be entitled to Medicare.
Okay.
They're probably going to audit the stuff out of your claims after you get past about 120.
Okay.
Because the actuarians are going to be sitting there going, they were supposed to die 10 years ago. Why are there still claims from this person?
Yeah.
Because they're going to be like, how is a 200-year-old person getting claims?
Right.
People audit their claims.
Okay.
And check it all the time. But, so, I mean, that's what they're doing. But the way that Medicare works is they're to cut costs and to make it sustainable. There's a piece under Medicare that is not covered. There are also parts of Medicare that a patient can opt into for an additional amount, but they don't have to. So that's something called Medicare Part B. And so Medicare Part B is typically covers things like outpatient physical therapy. So like if you were an old person and you had just been in the hospital and you had a knee replacement surgery and you have gone home. So Medicare Part B would be the part of your Medicare insurance that would cover a healthcare claim, that would cover a therapy claim. So if you went into just a physical therapy unit, that's the piece that they would cover.
Of the medical system. How is any common person supposed to understand any of that without having to pay people like you to break that down to it?
That's a fair question.
Most people don't. That's the true problem. Everybody needs to do their own research. And that's the thing is it's kind of hard to do that. But everybody needs to go and figure out what works best for them. What I like to tell old people is, when you go and look at it,
Old people.
you have the option to buy private insurance. You can buy an insurance policy that will replace Medicare.
Okay.
But the name of the game is how much do you have to spend to get to where your services, that are your covered services, because the services that are covered under a non-Medicare that are covered under a Medicare replacement policy are going to be the same level of coverage that you get under a Medicare policy typically, like the same services are going to be covered. Does that make any sense?
Yeah.
Typically, not always. There are differences. How do you get to a full level of coverage? So, like, for example, in skilled nursing, the first 20 days are completely free under Medicare. The last 80 days, you have a 100-day benefit. After 100 days, it cuts off.
Mm-hmm.
But the last 80 days, you pay a coinsurance. So it's $100 and something a day. It's like $180 a day. It's a real very expensive. So it doesn't take very long for that to rack up.
Yeah.
The question is how much do you have to pay for your insurance to cover that remaining coinsurance, right? That's how I like to tell people to think about it. And whether that's in a hospital environment, a skilled nursing environment, a doctor's office, what's the most cost-effective way to get to where all those services are covered? And typically what I've found is that the best way to go about it is to keep your Medicare, to buy Medicare Part B, which would be your physical therapy and all that kind of stuff, which is an additional premium that seniors opt for, and they just take it out of their Social Security. And then to find you a Medicare-approved Part D plan, which is for drugs. And so you would
drugs. You would cover the first thing I followed.
You'd purchase Medicare Part D to cover any drugs, and you would purchase a Medicare coinsurance policy.
Wait, so let me get this straight. Flat Medicare doesn't cover drugs.
No, it does not.
What does it actually cover then?
Medicare was designed to cover hospital stays, acute hospital stays.
Okay, so if you like an infection, break a knee, crack a hip, whatever old people do.
Yes. They think the way they think about Medicare Part A is hospital.
Yeah.
It is hospital insurance.
So that's our acute, oh no, something terrible happened.
Yes. Catastrophic injury.
And anything past that, we're going to have to purchase another plan.
Yeah.
Whether it's covered by Medicare or a separate insurance company is what you're saying.
Yes.
Okay. So how does that factor in to the quality of healthcare a normal person is able to receive? Because it sounds to me like a person who's able to afford, who's not able to afford like a premium healthcare service, right? Yeah. Is probably also not going to be able to afford those extra healthcare plans.
So Medicare Part A and Part B is very common. Most people that stay under Medicare have both, and that is usually very, very affordable.
Okay.
So that's not a big deal.
Okay.
The problem is when you start getting into the coinsurance and that supplemental insurance. That stuff can get very expensive. There are people that'll spend $300 a month on supplemental Medicare insurance to cover all the other incidentals and whatnot. And now part of that might be a combined plan where it covers the prescription drugs and their supplemental insurance. That's where it can get expensive. The supplemental policies, especially for the drugs, the Part D plans, those are usually relatively affordable. I know some people can spend as much as $100, $150 a month on those, but they're universal. So I mean, you just make sure that it covers the drugs that you care about. And, all the different insurance companies are going to offer you a policy, so you just find the one that's the cheapest one that covers your drugs, and you buy that policy. And so you have a lot of flexibility to kind of cut the cost. And so what the reason I kind of encourage people is to stick with this piecemeal system, right? Because that's what you're getting at, is it's not, nobody wants to have 6 insurance policies.
Right.
But while there are different parts to it, you're going to have like 3 cards. Yeah. You're going to have your Medicare card, your supplemental card, and your drug card. And so you got your 3 cards. That's it. And the reason I prefer that is because if you go the other route and you get with an insurance replacement, the insurance replacement may cover dental. It may cover your dental stuff. It'll cover your drugs. It'll cover all your therapy. It'll cover everything. The problem is they're going to stick you with all the same copays that Medicare would. Now, their copays may be less. So instead of paying $180 a day for coinsurance under a straight Medicare, you might pay $120 a day.
Okay.
But the reason I discourage that is you're still paying a monthly premium. Now, it may be like $50 a month, but when you have a major health incident, you're going to have to pay a significant out-of-pocket portion. You could have to pay a significant out-of-pocket portion. For people that are later in life, that don't have, that are depleting their savings to live.
Right.
Because that's how the system's designed. Once you retire, you deplete your savings until you die.
Right.
And then whatever's left is whatever's left.
That statement right there. So you're telling me we work our whole life just to pay into the medical system as we die?
That's the way the system's set up, isn't it?
Well, no, I'm
Things like
talking
that.
about more like living in general, not necessarily healthcare is that way, but
Well, that makes sense.
you work,
I mean,
just in life in general. As you work through the system, once you get to retirement age, you have your pot of money, and then you live off of it until you die.
I mean, that makes sense. If you retire and you don't have an income anymore, you're going to be living off what income's there and depleting it at least to a degree, right?
Yeah.
I mean, is that a fair assumption?
It's a fair thing.
I think that's a fair
It just
assumption.
seemed like that just came off as like we're spending it all on the medical system. But
No.
I mean, I would argue that a lot of people are, and that's a question I'm going to ask you later. So be ready for that. So let's go ahead. Yeah, sorry.
But so you have that and depletes, but it tends to be easier for seniors who are on a fixed income. Usually they have their Social Security money. They might have an annuity. They might have some other forms of income, investment income or whatnot. But they're, primarily these people live off of Social Security. And so when you're living off a Social Security check, it's a lot easier to have a monthly payment on your health care coverage than it is to write a $3,000 check once you've had a massive health incident.
Right.
And, for some people, after they have a massive health incident, let's say it's a stroke. They may not be able to handle their business anymore. They may have been perfectly fine and functional.
Yeah.
And now somebody who was living it up can't write their name.
Right.
And so, and then the families are all distraught because it's an emotional, traumatic thing for the family.
Yeah. Yeah.
They don't know anything about their parents' business because their parents handle their own business.
Right.
And now all this stuff is here, and they're like, well, now we've got to pay $3,000 out of pocket, and we don't know where anything is.
Yeah.
And so, that's why I kind of intend to encourage people stick with straight Medicare, find your supplemental policy, pay your monthly premium, and make sure that you are buying the right supplemental policy that covers all of the co-insurances, all the surprises. You're going to pay a significant monthly premium for it, but you're going to be glad you did because when you have a $10,000 hospital stay, you won't pay a dime. And it's worth that peace of mind because think about it. When you're an old person, there's a certain point in life where your body only starts to decline, right? Your body has hit its peak, its physical peak, and it's only going to deteriorate from here. Now, the speed at which you deteriorate varies. Somebody may live until they're 80 and have no problem, and you sit there and go, they're 80? An aged person, and then all of a sudden they may drop dead.
Yeah.
You may also have people that hit 60 and then they have a long, struggle with various chronic health conditions. You could say Alzheimer's, you could say, Parkinson's, various diseases, and it's just a long downhill struggle where they're chronically fighting their health.
Yeah.
And so for seniors, it's not a matter, people at our age have the benefit of we're healthy. And realistically, we're looking at, 40, 50 years without having any significant health problems, if we're looking at the average.
Right.
So that's not crazy. So for people our age, it's like, well, why do we even need health insurance? Well, once you hit a certain age, say 65, you're on the back nine. And so your health is only going to go one way, and it's not up. It's only going to decline.
Yeah.
And so it's wise to be prepared and to have insurance to cover you when your eventual health decline happens.
So let me ask you, what do you think about health savings accounts as opposed to things like insurance? Like if somebody wants to open up a health savings account at 30 and start putting money into that to save for later in life, is that a good option if they don't want to go the insurance route? Could that, protect them the same way an insurance policy would?
I'll be honest with you, I haven't studied those super closely.
Yeah.
I have not. Now, granted, because those are also kind of a more recent thing.
Yeah, yeah.
So I haven't, the aged population that I dealt with, that wasn't really a thing that was around when they were, saving and planning for retirement and for their health. I would say, so I never really dealt with that. That being said, I believe that there's certain restrictions on those kinds of accounts. Like you have to pay it at the end of the year. And so you put in a certain amount for the year, and at the end of the year, whatever you're still in there, you lose.
Oh, wow.
And so
Okay.
I've seen some things like that. I believe that's how it is with my work account. So like, if I put in $1,200 into my health savings account, it won't roll over.
Oh, okay.
So I have to spend it or lose it. And so if I have to spend it or lose it, well, there's no. I don't want to put very much in a health savings account.
Right.
Now there may be other options out there that I'm not aware of where it can roll over, and if it could roll over, and you don't have to worry about the taxability of it, because that's the big question on that kind of stuff is how much am I going to have to pay in taxes?
Yeah.
Because nobody wants to have taxable income, pay tax on their income, put it in a savings account, and then pay tax on it when they pull it back out to cover their health.
Yeah.
It's like, well, I'm just paying tax.
Well, you just described an IRA pretty much. I just let that
I disagree, but we're not talking
traditional,
about that.
not Roth.
Well, I do Roth. So.
Well, most people don't. Well, a lot of people don't.
I don't really even know what an IRA is.
Dude,
not
you're
gonna
missing
lie,
out
guys.
on some fun, man. IRAs, dude.
So healthcare savings account, in your opinion, maybe isn't the best option.
And that's the thing is, like I said, I don't know a ton about them.
Yeah.
And so
Okay.
I feel really kind of, I don't want to tell anybody, oh, you can't do a health savings account. You should never do a health savings account.
Yeah.
Because I don't know.
Yeah.
I don't know what would work.
Hey,
for
I
you.
dealt with
That's fair.
health savings accounts a little bit at the bank, and it's mostly just used for tax deferment.
Oh, okay.
Like the people that
Yeah.
are using those,
Aren't using them
they
for
can afford
healthcare.
insurance anyway.
Okay.
At least from my very limited experience. Now, I only probably dealt with 5 of those.
I would also tend to agree. It tends to be as much or more about a tax dodge than it is about actual covering health.
I got you. So let me ask you another question here because I'm curious. I have heard about a couple alternative insurance plans in the past couple of years. I don't know if they still exist.
Okay.
But companies instead of like subsidizing drugs and hospital visits, they're farming out their contracts to gyms and to health food stores.
Okay.
And putting these people on non-clinical interventions that should produce a particular health outcome, and then the insurance company pays out X amount based on whatever health outcome this facility is able to provide for their client. But this facility would be like a functional fitness gym, like a lot of these CrossFit and boot camp gyms that are popping up, or like a health food store that's really catering a dietary approach to their client, right?
Yeah. And if I can interject, So like an example would be, for me, in a dream world, I would lose another 10 pounds. And so if I sign up for a gym, this health insurance policy would pay out to this gym, if they could get me on a fitness plan and make me stick to it and lose my 10 pounds.
Exactly.
And so if I achieve the health goal, lose 10 pounds, they get paid.
Right.
For,
like let's say you
for
lose,
the service.
Right. Let's say you lose 5 pounds. They get paid X amount. You meet your goal X amount. You exceed your goal. They would make X amount. And what do you think about that as an alternative model to the way insurance is structured right now?
Well, so there is an element of outcome based or pay for performance fee structuring in healthcare in the skilled nursing environment, for example. They were just rolling that out. I want to say about 2018. They had rolled out or just rolled out pay for performance in skilled nursing, and the idea behind it was nursing homes that achieved the specified federal health outcomes for their patients. Typically, what they're measuring is something they would call RTA, return to admission. And so what that means is, does your patient go from a hospital to a skilled nursing home to home and then back to the hospital in a certain time frame?
Okay.
And so they would say, hey, if they're returning to admission back to the hospital, that means that the skilled nursing home probably didn't do their job when they sent them home.
Right.
And so when that happens, they would ding the skilled nursing home and the hospital. And so both of them get dinged on it because they're going to be like, hey, y'all didn't set this patient up to succeed, and it negatively impacts the potential reimbursement. And it strains the relationship between the hospital and the nursing home because the hospital's sitting there going, hey, we're not going to get dinged for all these RTAs because you guys aren't doing your job as a skilled nursing home, so we're not going to give you skilled nursing patients.
Yeah, yeah.
Because you guys aren't setting them up to succeed.
Right.
So there's all this pressure in skilled nursing to set the patient up to succeed.
That's good. That's a good thing, right?
And it's generally a good thing, but here's the problem with that model.
Okay.
So in a place like Tulsa, Oklahoma, the nursing home I was at was not even 10 years old. It was beautiful. It was, I mean, it's probably nicer than some people's apartment complexes. Like, I mean, it was palatial. It was very nice.
Probably nicer than my apartment complex. I had to go.
It was a very nice place. They had no problem doing a good job. That money wasn't really a problem at that facility.
Yeah.
It was, quite frankly, it was my company's probably flagship facility. What if they could have replicated that everywhere, put lightning in a bottle and put that everywhere, they would have.
Okay. Yeah.
The problem is, in that market, we could succeed and we kicked butt on all of those metrics. And so we could do all that super well. The problem is you take that to a rural community. We're sitting right now in Camden, Tennessee. This is a small community. They might have one or two nursing homes in the whole county.
Right.
These are working class people that may or may not have a whole lot of money. And so the home may have been built 50 years ago. So you're dealing with an older facility that may or may not have been specifically designed to treat and help patients recover. It may have just been designed as, well, this is where people that have nowhere else to go and can't take care of themselves go. It may have been designed as a home like that and not truly as a place of, let me help you recover and go home.
Yeah.
And so when you're dealing with facilities like that, the problem becomes the facilities aren't that great and they don't have a lot of money, so they have bad outcomes, so they get paid less. So facilities stay bad, and they're not investing because they have no money.
Right, right.
And they get bad outcomes. And it repeats a repetitive cycle of the rich get richer and the poor get poorer.
That's heartbreaking.
And so, I mean, that is the concern with that pay-for-performance model.
Right.
Now, my understanding is that CMS tried to be very careful when they laid that out because they, I'm with you. Pay for performance is a great thing. People that are great at providing care need to be rewarded for providing great care.
Yeah, yeah.
And they need to be encouraged to provide that care and proliferate that kind of care and help the American people,
right.
or any potential customer, any patient.
Yeah.
But the problem is how are you still respectful and make sure that you're not defunding people that are bad, because that's the thing, is who that's going to impact are people in rural and small communities that can't really afford the health care in the first place, and they're going to get punished for being rural, small communities.
Right, right.
And so CMS, basically, when they went through it, I believe that there was just a kind of a pot. So they basically said, only a certain percentage of your potential reimbursement is going to be impacted. And so a small piece. But they wanted to keep, the bulk of it to where, like you say, it might only be a 5 to 10% swing in potential reimbursement. Does that make any sense?
Okay, so you're getting some reimbursement, but it's not, the whole kit and caboodle isn't performance based.
Yeah, yeah. So there's like a baseline, like you'll always get at least a certain amount. Does that make any sense?
Yeah, yeah. So. That's interesting. Murphy, you have anything to add? You've been quiet over there.
Yeah, dude. The whole healthcare system seems so complicated to me. It's very hard to follow. You know so much because you were in it, but as an outsider looking in, it just seems like overwhelming.
It is, and I'll be the first to tell you, I only dealt with long-term care and skilled nursing, and that is that's a prevalent segment,
tiny niche,
but it's a segment of the healthcare market. I don't know anything about hospitals. I don't know anything about clinics.
Yeah,
I don't know anything about outpatient surgeries. I know some general principles. I know how the payer system works, which is basically your insurances and your private pays and your state insurance. So I know about some basic principles, but I don't know anything about the business side of those other types of services.
I got you. So let me ask you this, and this is kind of a loaded question, but I mean, does the healthcare model as it stands work for the people?
So that, I mean, for me, from my perspective, I think that's a pretty simple question. No, it does not work for everyone. People who are wealthy never have a problem, but people who are wealthy never have a problem in anything because, money kind of flattens their path.
Yeah.
Truthfully, I would say that the healthcare system kind of follows a parabola. And so on one end, you have people that are in absolute destitute poverty. On the other end, you have people that are filthy stinking rich. And it goes down, so it's inverted, I guess.
So an inverted parabola.
Yeah, inverted parabola. And so basically just a U. It's a U.
Yeah.
So on the left hand, you have people that are absolutely destitute poor. Well, if you're absolutely destitute poor and you're a senior, you can qualify for you qualify for Medicare because you're a senior. You can go and qualify for Medicaid based on not having anything, not having any real income. And so when you have Medicare and Medicaid,
everything's covered.
They'll cover everything. Now, when you go to the other end and you're rich, well, you're rich and you got money and you just, whether you got insurance or you don't, you just write a check and you got it. The people that are in the middle are the people that are kind of getting messed over because it's like...
Almost sounds like the other people that's paying for it.
Well, I wouldn't say that they're necessarily the ones that are paying for it.
At least early in
life. Yeah, I mean, in theory. But in theory, everybody who's working is paying for it. In theory. But these people in the middle will get messed over because they'll buy insurance because they know they need to buy insurance. But the problem is they won't look at what the insurance is, and so they'll sit there and spend $50 a month and think, oh, well, I've got this great insurance, it's going to cover everything. Come to find out, it covers about half of what they thought it was going to cover, and the part that they get assigned to have to pay is $4,000, and it covers half of it. It covers half of it, and then they have to write a $200 check on top of the $600 in premiums they've been paying all year.
Yeah, then they have to max out their credit cards.
And then they sit there and they feel butthurt because they sit there and go, oh, I've been paying money for insurance. And it didn't cover everything.
Yeah. I'd be butthurt too.
Which kind of goes into that old Latin phrase, caveat emptor, let the buyer beware, which is what you have to do with the insurance. And a general rule of thumb I'd give to anybody on insurance, I'd said this to old people. If your insurance doesn't cost you anything, it's probably not worth very much. That's not always the case, but if you're paying money for insurance and you're not paying very much, well, when you get sick, don't expect it to cover very much. That's been my experience.
Yeah, insurance is basically you purchasing money, or it's a purchase on yourself to fail, right?
Yeah.
Isn't that the idea of insurance?
I mean, that's kind of what it goes
with health, I would agree with
so
that,
the older you get, the more likely you are to fail. So it just seems like a lose all over to me.
I mean, that is kind of what it's sounding like. And, I mean, that was actually a question I was going to ask you is, can the average person afford insurance that actually matters? And it sounds like they can't.
I would say that they can. I would say that for a senior, I would say that they can. Now, for people our age, people that are working class,
yeah,
that's where it gets sticky. Now,
so you're saying Joe Six-Pack, once he reaches 65, 70, can go out and afford insurance that's going to cover whatever he needs as he ages and needs increasingly.
The idea behind that would be like Medicare and Medicaid, right? And the only thing you're really paying for is the various supplements.
Yeah.
So the question is, if Medicare runs out.
Yeah, if your Medicare runs out, you'd be in trouble.
Yeah.
Medicare runs out?
So basically we've got... No. This is a geopolitical question. We've almost got... What you're talking about is an essentially socialist situation once you hit retirement age for those that are poor.
Yes.
So your faith in healthcare is that continue to keep going, right? Otherwise, you're out of healthcare.
Yeah.
And that's why the average person can afford it.
Yeah.
Is because the previous generations are essentially paying for it currently. That and the
So you're saying that, like, well, I make nothing. So we'll take the guy who actually has a real job. You're right now paying for the insurance of the old people. Is that what you're saying?
Yes.
In theory, that's what's happening.
That's the case.
I would offer a different practicalities paying for it, but we don't have to talk about banking right now.
Yeah, that's fair. Okay, so the young people are paying for the old people, and when the young people are old, the next generation of young people will pay for their health care. Is kind of what's going on right now. That's what you guys are saying.
And another question there, not to stray too far off, but what is happening right now with people our age?
What do you mean?
We're not having as many kids as the elders that have been living. So once we reach that age, who's going to pay for us if there's way less people in the workforce funding this Medicare?
That's
just another
question.
Geopolitical question.
Yeah.
It seems to me like while it may be working at a base level on certain points, that you just described in great detail
how it does work.
Well, it does work
on a certain level.
For lower income people, it does get them health care. Now you may think that health care is not necessarily good, but maybe that's a topic for later.
I want to talk about that here in a little bit. But
my point, real quickly, is what happens when you run out of the payment, run out of people paying for it. Is there not a flaw there? What do you think about that?
No, well, I mean, and that's the thing is that it's a concern. I mean, it's crossed my mind what happens if there is no Medicare. What happens if you work your whole career planning on Medicare to be there and there's nothing there?
Paying into a system that you expected to pay out when you were ready for it.
Yeah. And so, I understand that. But
keep the train rolling as long as possible.
I would also tell you that with the way the world is kind of spinning, you're not going to see less government insurance. If anything, you're only going to see more.
Ain't that the truth?
So you're saying this engine's moving too fast and it's too big to slow down at this point?
Well, and that's the thing is I don't know what the future holds. I don't know what the future holds, and anything I'm saying right now is pure speculation.
Yeah,
but I don't see Medicare going away for seniors. Now, are they going to pass a universal health care thing? Are they going to go down some other kind of road? I don't know. And what is healthcare going to look like in 20 years? I don't know. But I guarantee you this: the people that are retirement age, 65 and older,
they ain't going to be able to see it.
They're gonna have insurance, and the government's going to provide it.
Okay, I mean that's. Okay, so your assumption is the government will continue to provide insurance somehow.
Oh yeah.
Okay.
Until, and I think I'm going to agree with Thomas here. Believe it or not, like it's still going to happen until the whole system fails.
Yeah. Well, and I mean, and that's the other thing. As long as our current system exists, it's gonna function this way.
Yeah, it's just interesting to try to break it down.
Well, truthfully, the concern for me is like, for me to be worried about Medicare not existing, I'd have to believe that the entire U.S. government system is going to collapse.
Well, okay, let's hang out here for a second because I want you guys to talk about this for a second. We're talking about money right now, right? How to fund healthcare, and something that I've been looking at a lot lately because this is what is going to be my life's work is the increasing cost of healthcare for the average person.
Yeah.
We're seeing skyrocketing rates of chronic disease in the United States. Those have been increasing exponentially for a long time, really since the 50s.
Yeah.
Things like diabetes, heart disease, cancer that weren't a big concern 100 years ago.
Mm-hmm.
Like over half of your population is getting those.
Mm-hmm.
Something upwards of 50% of the population of the United States has diabetes or prediabetes, like right now or will by 2030.
Mm-hmm.
And so the potential healthcare costs for the average person and for the nation on a whole are skyrocketing to the point that a lot of people I've heard talk about it are saying it's gonna bankrupt this country.
Yeah.
And so, a lot of my work and focus has been on looking at how can we cure these things. But my question to you is, what does that mean financially? A, if things keep going the way they're going, or B, if we do implement some kind of preventative wellness system, like what I'm working in now, fixing illness with food.
Yeah.
How can we assuage the damage we've already done to keep everyone from immediately going bankrupt?
So,
that's a big question.
First things first. I think that we have evolved in the world of medicine to where we can, and this goes beyond your issues with chronic disease.
Okay.
I'm going to address that secondly. We have evolved to a point where we can spend more money to save a life than that life is actually worth. Does that make any sense?
That's a big statement.
Well, and I don't feel like that's a very crazy thing to say, because you could in theory, you could take a person.
You're putting a monetary value on life right now.
I know.
As all insurance companies do, brother.
Well, I mean, that's huge. When the average person hears you can spend more than a life, is actually like that's just a knee-jerk emotional reaction that most people are going to have to that.
Think about this. All right, this is a perfect example.
Okay,
somebody has a car accident. They get hit by a train on a railroad track, and they lose.
And then they magically
they lose, and they lose all four of their limbs. They become a quadriplegic. They're still alive, and their brain is still active. And they're mostly themselves. Okay. You're going to spend hundreds of thousands of dollars just at the hospital.
Right.
Amputating, healing that person, saving their life, spending money on drugs. You're then, after you've done that, you're going to spend tens of thousands of dollars to get that person therapied and adjusted to life in a new wheelchair.
Right.
You're going to then spend thousands and thousands and thousands and thousands of dollars more than you would have for a normal person just to sustain them as a quadriplegic. And regardless of what they were before they had their accident, their ability to earn an income is going to be greatly diminished. And so it doesn't matter if you were, a world-class lawyer, you flipped burgers at McDonald's. Now, all of a sudden, unless you have the money just sitting in a bank account, if you pretend that this person walked in the hospital without a dime, you're about to spend, $1 million in the next year to get this person to where they can function.
Right.
Not counting what it's going to cost to keep this person alive every year for the rest of their life.
Right.
Can this person pay in $1 million into the healthcare system to cover their costs? Now, part of the idea behind insurance is also, if you have a catastrophic accident, because all three of us have insurance, if I have one that's truthfully more than what I'm going to put in, they're betting that you and Murph won't, and that you guys being healthy will cover the fact that I'm sick.
Yeah, it's kind of like a pool of money.
But that's the thing, is we have developed these things like, ventilators, like life support, like all this stuff. And we can sustain life long beyond when it's truly living. I mean, there are people that are in comas that have been kept alive for years, decades. And so, we can sustain life indefinitely at great cost. And, so what's the solution there? And for me as a business person, I look at there and I go, well, there comes a point where you just need to cut somebody off and let it go.
And cold,
and you say that, and it's very cold, but it's it's calculating and it's rational. But when you reconcile that with our biblical beliefs of everybody has a soul and is made in the image of God, and that when we were conceived in our mother's womb, God knitted us together intimately, and so God knows us and made us and created us and loves us, and so when you kind of have that, it's kind of like, well, at what point is a person not worth saving? And that's such a deep thing.
Yeah.
And I don't pretend to have an answer there.
I don't pretend to have an answer. I just want to make a quick comment about that. Like, that thought process you just went through, talking about the numbers and what a person's worth and can they pay it back into the system, and you went to the biblical worldview. What can a corporation do? Make that second step.
What do you mean?
My point is, like, a corporation cannot, as an entity, make valuations on souls, right? Humans are just numbers.
Yeah.
So, would anybody consider that a problem, or is it just the way it is? So, I mean, that's my point. Because we live in a corporate system.
Right.
So I think this is a great segue into something that we had conversations about this before we started this interview. But a great segue into alternative options for a healthcare system. Because in the United States, we have a capitalist system. The government, takes care of the old people.
Quotes, but
yeah, we have a capitalist system. The government takes care of the old people and the poor people. Everybody else is on their own. And so typically that means that people either have insurance through their employer provides the insurance, and they pay a portion of that premium.
That seems to be getting worse and worse as time goes on.
Personally, I have great insurance with my employer, but
I'm so happy for you, Robert.
Good, but
congrats,
the
buddy.
picture.
It's American,
from what I
capitalism
hear,
is working for me. I sound like a little bit like a jerk, but capitalism is working for me, man. I love corporate America.
Obamacare kind of
straight from the horse's mouth.
Kind of really hurt that whole situation.
That's what I've been hearing. Yeah,
and so you got that piece, but then everybody else who either doesn't have an option from their employer, or is self-employed, or doesn't like what their employer has to go and buy their own insurance.
Right.
At whatever the going rate is.
Yeah, but there's a problem with that, though. Like, who sets the going rate? Like, aren't you not allowed to cross state lines?
Like compete across the state line?
I believe so, because I know for Blue Cross Blue Shield in particular, they have a Blue Cross Blue Shield in every single state.
Yeah. Wasn't that one of Trump's big running
that was one of his big
platforms? That he was going to abolish that law?
I'll be honest, I got out of healthcare and I stopped following healthcare news.
That's well, I mean,
yeah, we should probably talk about that too.
Well,
talk about
why you got
let's go down that system, that alternative system.
Okay.
Because we're talking about the government.
Yeah.
And we're talking about how the American system works, and I think most people kind of have an idea. They've seen it.
Right.
And so that's what the American system is. And so there's a big push, in particular in Congress, and particularly among the left wing line of thought, to go to a universal healthcare system where the government is the primary payer for everybody.
Single payer.
A single payer system. The biggest concern I have with that, and see, that's the thing, is I don't pretend that the current system we have is working. I don't think anybody does. I don't think it's working, and I don't think it's the solution, but the only other alternative being suggested is this single-payer system. Well, where's that been pioneered? Europe. When you look at European healthcare, yes, everyone has access, but what do they have access to? So start thinking about that. Because what you've seen in countries like, say, Spain, where everybody has access, but they're realizing, hey, we're not that wealthy and we can't really afford all this.
Right.
They had panels of doctors that sit there and decide, hey, can so-and-so actually afford, or can we actually afford to give so-and-so certain medical treatment?
Yeah,
is that a viable alternative?
That's what I want to mention. That goes on in Canada. They're called death panels.
Yeah.
You literally have doctors deciding who gets treatment.
Wait, so if I have a deadly illness or something, there's a group of people who are going to decide
who's
if I
most
get
likely to
treatment or
afford
not.
the treatment. Yes.
Yep.
It's called a death panel.
Outrageous.
Yep. And so they go through and they make those kinds of decisions. But the other concern I have is that they kind of single themselves into a certain line of thought. They're going to sit there and say, all right, for a certain condition, there's two primary treatments, treatment A and treatment B. And so they're going to decide what the most effective treatment is. And so that's what they're going to pigeonhole people towards, these accepted treatments.
Okay, so can I stop you right there for just a second?
Yeah.
Keep your line of thinking. I just want to.
Yeah, that hurt Carson. I can tell.
That hurt me big time. As somebody, so most of my work and study is in alternative healthcare practice, right?
Yeah.
And I mean, obviously, here in the States, we have fantastic acute healthcare. Like if you have a really bad infection, or if you break your leg or something, freaking go to the hospital, please, and get it taken care of.
Yeah.
But as far as
rub dirt on it.
Yeah, right. I mean, well, that's another story. We can get into dirt later. But as far as a lot of other conditions, like if you don't have something that's immediately life-threatening, we do a really terrible job of taking care of that.
Yeah.
And a lot of the healthcare interventions that I've studied or am studying aren't necessarily the primary path of choice for the medical system, right?
Yeah.
And so in a world where the government takes over the healthcare system, I would be absolutely terrified, because the interventions I see as being the most useful, the most practical, and the most curative, meaning that you have the highest chance of curing whatever disease you have with this intervention,
Yeah.
those interventions would not be the primary treatment. And, things like diabetes, cancer, chronic heart disease, those would not be treated the way I would want to be treated personally.
Yeah.
And so I see a huge, huge problem with somebody else deciding what I can have done.
Can I just make a real quick summary of what you just said? But basically, you're saying, because right now our current system is already not tailored to that.
Right.
But giving a single-payer system, the simple option for that may be destroyed.
Would just be taken away, best I understand it.
And it could be. See, and my concern with the single-payer system is, one, I feel like it stifles innovation. The government is going to mandate, these are the options, this is what we're going to pay,
and everybody
get on board.
Yeah.
And so that's going to determine the quality of care. And so, if you throw more money into it, sure, you'll get better stuff and whatever. But to throw more money at it, you have to go to the people and say, all right, we're going to raise your taxes 5, 10, 15%.
Right.
And that's never popular in this country, or any country for that matter. But so that's part of it. But they're also going to sit there and they're going to choose the options. And so that's the thing, is the government can then incentivize what the preferred course is. So let's say, for example, treatment A and treatment B. Well, in certain, the government may say, all right, you can't get treatment B unless you've had treatment A, which means, if there's a patient and they meet a certain criteria and you're like, I know that treatment B is the most effective treatment as a doctor. Well, they won't authorize treatment B until they've had treatment A. So now I have to waste time on doing a treatment that I know isn't necessary and isn't effective, and to get to treatment B. Or you could have a situation where it's like, yeah, we'll agree to treatment B. It's doctor's discretion, but treatment B costs, $750. Treatment A costs $500, and we're going to reimburse you $1,000. What is that hospital going to be incentivized to treat with? Right. They're gonna prefer to do treatment A on every single patient that they can do treatment A on.
That's a problem we have now.
It maximizes the profitability of the service.
Yeah.
And in theory, if the patient gets well, it doesn't matter. Where that starts to get slimy is when you sit there and you go, well, are you incentivizing profit or whatever?
Right.
And that's the thing is, then people can sit there and try to tweak it and do whatever they want. But the ultimate thing is once the government gets control of all the healthcare, their biggest problem is going to be being able to afford it. And so they're going to be looking for every possible way to cut costs. And so whether that's at the facility, as a facility thing, cut costs at the facility, cut costs in doctors, cut costs in drugs, cut costs in whatever. They're going to be looking for ways to tighten that thing so that they don't have to go to the American public and say, hey, we need more money to cover the cost of your health care.
Right. It's like a two-way monster. You're going to be losing quality of service, and some people are going to lose their jobs.
Yeah, that sounds horrifying.
Well, and so this is my favorite statistic when it comes to the innovation of it. When you look at patents, healthcare patents for just medical drugs, medical devices, whatever.
Vaccines.
Yeah, and vaccines.
We're talking about that
the
soon.
Overwhelming majority of them, say 70%, come from the United States. When you look at the patents for medical devices, drugs, vaccines, whatever, that are for products that are of critical life-saving nature. Does that make any sense? So like a vaccine for coronavirus, critical life-saving whatever, right?
Allegedly.
Allegedly. You have an innovation like that.
Yeah.
70% of those patents still come from the United States. And so the United States is the overwhelming leader in innovation in the healthcare industry. And so my concern with going to that socialized medicine is that we will kill the world's best chance at healthcare innovation. And that's the thing is, we've learned so much, and we can do so much. We're doing so much better than we were, say, even 20 years ago. But there's still so much more that we can learn. not that we can ever cure everything. You know, I think there's certain things that are always going to ail man, and people are always going to get sick. I mean, the common cold, we can't treat the common cold.
That's true.
It's not through the medical system, that's for sure.
Yeah. Well, I mean, and that's the thing is there's nothing we can do about a common cold. But, you know, then again, we're not really worried about it because it's not going to kill us.
Right.
But that being said, like,
that's a whole other discussion.
There's so much more we could potentially do, and I hate to cap that creativity.
Yeah.
Because basically what we do is we then shut off the funding faucet to that innovation.
So you're saying that the maybe not wholly capitalist, but capitalist nature of the healthcare system that we have here in the States is kind of fueling the creative energy of the healthcare system.
I mean, that's my perspective, and I'll be honest with you. There are people that on the other end that would probably argue that socialized medicine is much more effective than the way I portrayed it. But I've kind of portrayed all the negative stuff of it. The major perk, though, is that, you know, if you have a common ailment, like let's say you're having problems with your gallbladder, you know, a relatively standard thing, or appendicitis.
Yeah.
The appendix is in danger of rupturing, right? Well, the perk to a socialized system is anybody in the country can walk into any hospital in the country with appendicitis and have their appendix removed and not pay a dime.
Right.
That's
crazy.
Because that's the thing is when you think about the healthcare system, what do you want healthcare and insurance to do? When I'm sick and I'm in pain, I want to walk in and see a doctor and I want to feel better. That is the greatest attribute of socialized medicine is anybody in the country can walk into any healthcare provider, say, here's my number, I'm sick, I'm in pain, I want to be treated. And that is a huge benefit. The question is that the outcome that's actually going to be achieved? Does that make any sense? So my concern is that's what socialized medicine is selling. Anybody can walk into any clinic anywhere and be healed. I question if anybody can actually walk in and actually be healed. Does that make any sense? Because that's my concern is, you know, it might work for most of the people or some of the people, but what happens to the 15% that have chronic debilitating conditions that there's not really a good answer for? What's happening to them?
Yeah.
Are they going to be treated? Are they going to be taken care of? Are they going to be able to say, yes, I walked in and saw a doctor and I feel like we have a meaningful plan that's actually treating my symptoms and helping control or treat my disease?
Yeah.
And I don't know that socialized medicine can answer that question with an affirmative answer.
That, to me, is a pretty good segue into maybe a third option. And I know, Carson, you're real big on the third option. So option A is what we currently have, the status quo, the capitalistic socialized fusion that we call America. Option B would be the single-payer system of socialized European countries, basically. And then option C, don't go at all. It's called wellness, Carson.
I mean, yeah. So, yes, that's the thing I'm the biggest fan of is
all this can be avoided, right? In theory,
obviously, if you break your arm and you get MRSA, that can't be avoided necessarily. But a lot of these chronic conditions, in my opinion, can be avoided. But what's your point?
Honest, that's the big money maker.
I mean, yeah. If you can, so if you can medicate somebody until they die, that's going to make you a lot more money than if you have a healthy person as a patient, right? Because, like you say, doctors are paid out based on what they diagnose, right?
I wouldn't say that doctors necessarily. I mean, they can be. In my business, the facility got paid. The doctors were just employees of the facility.
Well, right. So, I guess your facility isn't paid if, Frances, who's 93, can still live on her own and take care of herself. You guys don't make any money.
Yeah.
And so it's financially better off for you guys.
Oh, yeah.
If Frances, by the time she's 73, needs to live in a home
Yeah.
And you can keep her just well enough to stay in that home until she's 100 and dies,
as long
right?
as she's paying.
Yeah.
It is way more financially advantageous for a facility like you were in to do that, as opposed to get her well in 6 weeks and send her back home and give her the tools she needs to stay healthy for another 20 years, right?
Yes. Now here's the deal. So, it depends on what we're talking about, right? So typically the people that come in on skilled nursing, typically the goal is to send them home.
Yeah.
Our anticipation is this is a short-term stay. You're going to be treated, and then we're going to send you home. That's typically the plan. Now, there are patients that will come in, and we start treating them, and it's like, like say a stroke survivor. It's like you can't put your clothes on. You can't go to the bathroom by yourself. You can't do these functions reliably on an independent level. And so we're going to tell you now that you need to find a home. You need to be institutionalized because you can't perform the functions to take care of yourself. And so typically when we tell people, hey, you need to stay in this home, repetitively, and from now on, we don't do that because they have another option. Because that's the thing is, if they have another option, we're going to tell them take the other option. Because our facility in particular didn't really have beds to keep people long term.
Okay.
And so people wanted to stay there long term, but we didn't have beds for it. And so it's like, well, you need this long term thing, but you can't stay here. So we would then facilitate a transfer wherever they wanted to go. But
we've got too many of you. We need to get you out.
Well, yeah. So and that's just the thing. And so that's the deal is, a lot of, at least for us in what we were doing,
yeah,
it was typically, we wouldn't recommend that until it's like, and half the time those families were in denial. They're like, oh no, they can go home, they can take care of themselves. It's like, he can't pick up his right arm. How is he supposed to go home and live by himself and not fall and die? Like, we're just sitting there like, you're out of your mind thinking that this guy can go home. And so, like, we dealt with a lot of situations like that. And I would tell you that my experience in my industry, more often than not, the problem was people needed to be institutionalized, and they were fighting it and trying to go home. And think about it, meet somebody that says, yes, I'm so looking forward to the time in my life when I get to go sit in a nursing home.
Never heard that once. Yeah,
never heard that once. You'll never meet anybody tell you that, because nobody wants to go there. Now, it's a perfectly viable option, but more often than not, people fight that as long as they can, and quite frankly, a lot of times, past when they should be fighting it. They should just give in and be taken care of.
That gets into a whole other discussion in the role of children.
I mean, that and just the health care that a lot of these people are receiving in the facility in general.
Yeah, but we can't stay here all night.
We can't. So we're right at an hour.
I want to ask Thomas a question.
Okay.
And then maybe you can, what are we going to do this time? Dock the ship, or did I say that last time?
Yeah, we're out here on a lake. We can dock the boat.
That's true. Thomas, well, why did you get out of it?
So the reason I got out of it,
out of healthcare.
My
context, please. Right?
My job was to collect the private pay insurance piece from old people. And so,
what does that even mean?
So remember we were talking about
like Ebenezer Scrooge.
We were talking about Medicare, and there's that coinsurance piece that Medicare will not cover.
Okay. Yeah.
And so for people that don't have insurance, they have to pay that out of pocket.
Right.
And so my job originally was to go to the facility and to call those people and say, hey, we need you to pay your private pay piece. And so, there are a lot of times there are people that are like, I'm poor, I can't pay it, whatever. And so it was my job to try to collect it. If I couldn't collect it, get it written off so that we can have an accurate statement of how much accounts receivable we had actually on the book. And so after about a year of doing that, I got promoted to a regional financial consultant role. And so at that point, I was managing 5 nursing homes, and I was going to 5 different nursing homes, overseeing the business office, making sure they did their documents right, and that they were actually doing that billing piece and going and sending out those statements, calling those patients or former patients, and making sure that we got paid.
Yeah.
That private piece.
Okay.
So that was my job, and the thing is, I love the people I work with. I quite frankly, I still miss some of the people that I worked with. I really enjoyed the people I worked with.
Yeah.
But it was just such a soul-sucking thing for me.
Why is that?
Because
taking money from poor old people.
Exactly.
That seems like pretty brutal to me.
Yeah, it was. I mean, that was just one of those things, and you get to know certain people.
Yeah.
And of course, quite frankly, once you didn't pay me, then I got a little mad. But
that's
there's the Thomas I know.
$90.
But like that's the thing is, it's like she was such a sweet old lady, and now I have to go and call her and. Yes, ma'am, you do owe me $3,000, and well, I don't want to have to do it, but I'll take you to small claims court, and we'll hash this out. And
oh my gosh!
I mean, yeah, I've been to small claims court over
$3,000.
It was a little bit less than that, but
over less than $3,000.
Yeah, look, man, it's
taking somebody.
I was an accounting major too. It's important to get these statements right.
I mean, doesn't it cost more than $3,000 just to take somebody to court?
Well, that's a whole different thing. I thought that whole thing was no good. And quite frankly, I treated it mostly as a bluff.
Intimidation tactic.
I see.
Actually, you're not supposed to threaten when you're collecting Medicare balances. That's a big no-no. But
you did it anyway?
I had taken people to court. Usually, I would send out these nice letters on company letterhead that would tell them we're going to do this, and usually that would scare them into paying me.
Hey, by the way, we're going to sue you. That's real nice.
And we would have. I mean, like my boss was.
But you're supposed to be non-threatening. She
was a sweet lady, but
letter of the law.
She was more than willing to take these people to court, and I just didn't like that, man. It was not good for me.
I can understand.
And so that's why I looked for a change, and I got out.
So what are you doing now?
I do taxes.
Woo, fun.
I love taxes, dude. It's great.
Yeah, well, we've already been going for like an hour. I don't think we can go another 15 minutes.
We definitely can't talk about taxes,
Thomas.
I think taxes is a discussion for another time. I'm not the one taking the taxes.
We can have you on again. You're just advising the thieves.
Right.
I'm just advising. No,
actually,
you're
advising
the
victims.
People. I'm advising the people that aren't paying the government.
Yeah. Wait, what?
We'll talk about it later.
Yeah, we'll have them on for.
That sounds illegal.
When we're not interrupted.
I like talking about illegal stuff.
Bros at the lake.
Yeah.
For anybody who watches on YouTube, they should go out by.
All right, guys. He did, but that's okay. That's okay. Is there anything else we need to go over before we
it's just been fun.
dock this vote? Thomas, thanks for coming on, man. I really appreciate it.
I did. This was fun.
It was good to get some answers about some of this stuff because I've been wondering about a lot of the things you told us about for a long time. So it was good to actually get some answers on that.
And quite frankly, I mean, I'm by no means an expert, but I'm happy to share what I know, and I enjoyed it when I worked in there. I loved knowing about insurance and trying to help people make informed decisions that would work for them.
Yeah.
That's what this is all about.
Yeah, I like that line of thought.
That's the part I can get on board with.
As corrupt as the system is, at least there was a guy in there trying to help them with what they had.
Right. Well, let's at least help you make whatever life savings you have go as far as we can make it go.
Well, and all right, so here's a fundamental thing, too. Like, whether you like the system or not, it is the system.
Yeah.
It's what we got.
Right.
And so you can either learn the rules of the game and play the game, or you can sit there and be mad every time somebody says, penalty, that's a foul, you can't do that. And so, you can learn to play the game, or you can be penalized. And so it's like, I want people to play the game and play the game well, because once you figure out the rules, there's no reason you can't win.
Right.
Or at least be in a strong position.
Maybe break even if you're lucky.
Yeah. For real.
Yeah. That makes sense.
All right, guys. Starting to run the jet ski. I think they're throwing footballs to each other.
Yeah. I think it's time for us to back out of this bad boy. Yeah. Robert, thank you for coming on. It's been a blast.
It's been a pleasure.
Guys, thanks for listening. Let us know what you think.
Yeah.
If you agree, disagree, got really pissed off, got really excited, whatever, let us know. You can find us on Instagram, YouTube, Facebook, Twitter.
Yep, rattle them off.
Spotify,
Google, Apple Podcasts.
We're all over. You have no excuse not to listen to us. We love you guys. Thank you for listening.
You want us? We need sound equipment to help muffle out this horrible background noise that we're currently experiencing.
Right.
So Patreon and subscribe star.
We want to make this better for you. That's our goal.
We want a ripe product for the picking. There's another one.
The right product for the picking.
Right. So I'm comparing that to a fruit.
Yeah. Everybody likes fruit. All right, guys. Thanks for listening. We will see you next time.
Yep.
All right. Bye-bye.